Good morning, everyone, or I should say good afternoon, especially for those on different time zones. East Coast, you guys are an hour ahead. Pacific Mountain, you guys are an hour or two behind. My name is Hiva Kolodrubetz. I am a family nurse practitioner, and today's webinar is focused for advanced practice, but I always love to see my RNs joining as well, or our RN students, because I think if you're interested, you can learn a lot. Let me get rid of this little timestamp. There we go. So like I said, my name is Hiva Kolodrubetz. For those of you who don't know me, here at Archer, we have combined our streaming and our social channels and all that good stuff. So you're going to be seeing me from time to time, as well as my other colleagues who are advanced practice, like Dr. Morgan Boosie and Dr. Morgan Taylor. So you guys are already familiar with Dr. Taylor from the nursing world, but you'll get to see a lot more in the advanced practice world too, if that's something you guys are interested in. So for my students that are on today, if you're joining me from the Zoom account, you have the chat open. Let me make sure you guys can put things in the chat. And I want to hear from you guys, but I want to see where are you from? I see some familiar names and faces, but I always like to get to know my students. I'm sure for those of you who have taught, you know the importance of that, because it's nice to know where are your students at in their nursing journey. What are they looking for out of this webinar? So I want to know, what are you looking for out of this webinar? Are you getting ready to sit for your boards? Do you have a pharmacology exam coming up? Why did you join today's webinar, and what can I make sure that we cover today for you, right? So that's going to be really important. This is a rapid review, so meaning that I'm experimenting with how fast we can go through as much pharmacology as possible. We're going to do some exam questions as well. One thing I love doing with you guys is really just showing off our question bank. So today I'm going to show you, and I'm going to go through all because I always do this, and my exam questions aren't really complete, so I'll use all of them. But we're going to go through some pharmacology together, and we're going to do it in all the systems, right? So that's going to be really important. So we'll get into that as well. But let's have some fun and see how much Pharm we can get through, right? So let me take a look at my chat before I jump in and see if anyone is saying hello, if I see any students kind of telling me that there's something they want to get out of today's webinar. Let me know, you guys. Hello, Nairi from California, LA area. Very nice. I love California. I lived in Northern California for a little bit while my husband was finishing his training, and I got to work at a great healthcare system in internal medicine. So that was fun. Nairi, are you a nursing student, an NP student? Where are you in your nursing journey? I'd love to hear from you. Patricia, good to see you again from Connecticut. Patricia, remind me, are you a NP student, APRN student? Or an RN student, remind me where you're also from. Angela, welcome from Kenya, NCLEX, 2 weeks away. So exciting, Angela. I know it's probably very scary, but I'm so glad you can join us today. Patricia is an APRN student. Okay, Patricia. So we've got a little bit mixed, right? We've got some RN students, some NP students. So again, you guys will have to be looking out for who's the target audience for these webinars that we are now combining into one social. Today, we're going to go higher level, but that doesn't mean for my RN students that you won't get something out of this today. You just might not have to go in as in depth, okay? So some tips and tricks with pharmacology. So remember, when you're getting tested on pharmacology, whether it's on the RN level or the APRN level, they always are testing you on safety, because as APRNs, as nurse practitioners, when we're prescribing, we need to be thinking about safety, right? We need to think about what are those potential adverse effects, what are those contraindications for our patients, and is this a safe medication for my patient? And then we also have to be explaining to patients how to take these medications, What are those common side effects that they should expect? And what are those side effects that we worry about that they should call the office, right? So safety is the biggest thing. And as nurses too, when you're on the bedside, you also want to know the safety parameters. That's why you might see it on your NCLEX exam as well. I'm not going to get into that today, but safety is always first thing you want to be thinking about. So with the drug classes, always think safety first. So when you have a test question in front of you, think safety first. What does that mean? So it really, all the things that we just talked about, right? But you want to be thinking about those patients who have organ damage. So liver failure, kidney failure, maybe they won't be able to metabolize the drug as well or excrete it, right? That leads to toxicity levels. And then you also have parameters that are different for children and elderly. Again, it's because the way their body metabolizes, absorbs, and excretes the medication is going to be very different. Their body sizes for those kiddos are different. Their body processes things differently. And our geriatric patient, that also starts to change as we age. That's normal aging process. So really thinking about the pathophysiology of the drug class, how it works in the body, and what are those parameters based on my patient, right? Case by case scenario. A lot of questions also might have really obvious things about like pregnancy, breastfeeding. There are a lot of precautions around pregnancy and breastfeeding, so we need to be mindful of that. That's also a patient population that we need to be thinking of when we see these pharmacology questions. All right, jumping right in. Again, for those nursing students on here, these are APRN style questions. So this is more for nurse practitioner boards. I clicked on the ANP model. Let's do this first one together, and then we'll do one from our dashboard too. And you guys can put your answers in the chat for me. You can also put your answers, I guess it's just chat because we're streaming on lots of different channels. So NIREA FMP certification, very good. Okay, so it sounds like we mostly have some NPs on the channel today, which is great. So let's go through this first one together. Patient has been diagnosed with hypothyroidism. You're going to see this a lot, especially for my NPs who are getting ready to sit for their family nurse practitioner or adult gerio and primary care. Those exams, those board style questions are going to be really highly focused on what you're going to see in primary care practice. And what we see in primary care practice is a lot of these conditions like hypothyroidism. So I want you to be thinking about not how you would be managing it if you were on the inpatient side. This is different now. You're on the outpatient primary care side. So we really need to be thinking about that lens in that setting when we're thinking about these questions. So in this patient, they've been diagnosed with hypothyroidism. We do this a lot in primary care. Nurse practitioners beginning levothyroxine, 25 micrograms, very good. Start low and go slow. You may eventually go up to something that's more going to be bringing their thyroid levels to goal. So as you guys probably know, levothyroxine synthetic T4, this is weight dependent, but you're never going to start someone on what they'll eventually need, like 88 micrograms, because that's going to send them into a hyperthyroid state. So you always want to start low, go slow, and keep checking those labs and titrate. So in this scenario, nurse practitioner, they're telling you they're starting this patient on 25 micrograms. In review of the patient's current medications, which of the following will require specific education for use concurrently with the levothyroxine? And Synthroid is the generic name. So remember, why are they asking you this question? The first thing I always tell my students, let's look at what is the question asking? It's asking you about patient education, right? You need to educate your patients on how to take these medications, especially medications that really require a specific way to take it because it minimizes those side effects. And I'll talk about that in a minute. But what do you guys think? So what should we be thinking about with a patient who is starting levothyroxine for the first time? What are those other medications on their med list that we want to educate them on? So is it A, omeprazole, Prilosec? So you'll also see the generic with the brand on the ANP and ANCC exam, so you'll get both. I tell students to focus on the generic, and we'll talk about that in a minute too. Is it B, escitalopram or Lexapro, C, atorvastatin or Lipitor, or D, lisinopril or one of the brand names is Lestril. What do you guys think? So Patricia's weighing in. Let's see if anybody else is weighing in. Let's see, let's see. Yes, you guys are awesome. Ruth is weighing in. I'm seeing some others weighing in. I can't pronounce that name, so I'm not going to butcher it, but I see you. Hi, welcome, welcome. All right, so the answer is A. Absolutely, you guys got it. Why? Why is the answer A? I know this is a rapid review. I'm really bad at rapid reviews because I just want to go into the nitty-gritty of why. Um, but why do we need to know this and why do we need to educate our patients on this? So levothyroxine, synthetic T4, it's not only weight dependent or specific to the patient based on their weight, but it also needs a highly acidic environment for its absorption. So if you have a patient who's on a PPI like omeprazole, what happens with a PPI? You're blocking that proton pump inhibitor, so you're decreasing the absorption, right? So I'm sorry, you're blocking the proton pump inhibitor, so you're decreasing the acidity in the stomach. So what ends up happening is you may not see, if you don't educate this patient on this medication, you may not see the levothyroxine really working for this patient, and you'll keep going up and up and up on the doses. And then what happens? When you're so high on these doses because you're not utilizing this medication appropriately, it can lead to toxicity. It can lead to more potential side effects. So we really want to make sure we're educating our patients on how to take their medications properly so we can use the lowest effective dose and avoid those side effects, right? So answer is A, absolutely. When we have patients on levothyroxine, we want them to take it on an empty stomach, nothing to eat for 30 to 60 minutes. It's really hard in our pediatric patients. Think about those kiddos who have hypothyroidism. I always tell mom and dad, do it right before bedtime. As long as there's 4 hours in between dinner and when they go to bed, they haven't had a snack, that's still an empty stomach. Because usually kiddos will wake up, they're really grumpy, they're really hungry. It's hard to wait that 30 to 60 minutes. And then you get the tantrums. I've got two of my own cuties at home. I know what it's like. So just make sure it's on an empty stomach and whatever works for that patient. Awesome job. That's right, Patricia. It shouldn't be taken with antacids, no PPIs. Very good. Awesome. All right, next question. I have all my different screens open. Look at you guys. I love it. Miss Doris weighing in, Lizzie weighing in, Rose weighing in, Ruth. You guys are awesome. All right, rocking and rolling. Next question. Let's see. So 68-year-old female, a male patient complains of urinary frequency and weak urinary system. So he denies erectile dysfunction, ED. Urinalysis reveals no abnormal findings, and his prostate exam is normal. So I will say this, if you're getting blood work done, please don't do the prostate exam in the office if you're getting blood work right after the exam, right? Because when you do a prostate exam, that's going to affect the blood work. The PSA is going to go up. So if you're checking a PSA, we don't do prostate exams routinely anymore. They're usually used, those rectal exams are usually used if patients are symptomatic and I'm worried and I want to feel the prostate and see what's going on. But if you're doing routine and you do that prostate exam, then they go to the lab and get their PSA drawn, that PSA is going to be high. So this there are many reasons why we stop doing the prostate exam as part of our routine, but if you do a prostate exam, just have the patient wait a few days before getting those labs done, just so we don't have a falsely elevated PSA. That's a little clinical pearl for you guys. All right, so urinalysis reveals no abnormal findings. Prostate exam is normal. Nurse practitioner plans to treat the patient for BPH. What is the appropriate medication to prescribe? What do you guys think? A, is it tamsulosin? B, oxybutynin? C, tadalafil, which is Cialis, or D, finasteride, Proscar. What do you guys think? What is going to be the most appropriate for BPH? And I know we're kind of jumping around. Again, for those of you hopping on late, that's what I'm trying today. Let's see how it goes. Even though I'm fighting the urge to go in depth with a lot of these things. What do you guys think? All right, Patricia has weighed in. Let's see if anybody else is waiting. The writing's very small. Sorry, Ruth, I know. You know what? I've gotten that feedback about when I streamed this Q bank and I forgot it. So I apologize for that. So zoom in, everyone's saying zoom in. Let me see if I can zoom in. If not, then it kind of, ooh, is that better? I can zoom in. Okay, why didn't I think about that? You guys are geniuses. Sorry. All right. So Nairi is weighing in. All right. Looks like majority rules, and we're going to go with A. So what I like about our Q bank, especially in the tutorial mode, if you're using it in tutorial mode, you'll take your best guess, and we'll talk about, well, I'll do a session on test strategy. Oh, I don't know what I did. I'm trying to zoom out so you guys will see the whole thing and what it looks like, and then I'll zoom back in. So in that tutorial mode, it'll give you a lot of great things. So it'll give you the right answer, but it'll give you the explanation, which is very, very important. Excuse me, getting over a cold. Even if you got it right, I highly encourage you to read the explanation because sometimes it might not be what you thought, right? I always want to make sure you guys understand why the answer is right and you're not just memorizing it. The other great thing is these test questions are really a way for you to identify those areas that you need to go and read more about. So if you're getting it wrong, see that as a growing opportunity. Don't get bogged down on that. A lot of my students avoid test questions because they get really nervous because they're getting them wrong. And I say, no, that should help focus your study plan. And if you're not feeling like it's doing that, then you and I need to talk. We need to schedule a meeting and I need to help you focus a little bit more. But it's a really nice way to identify those knowledge gaps, go into the why, but it's very like direct. So the why is not going to be fully comprehensive. You need to go back and read more in that section if it's a section that you really struggle with. It's really important. We also have these on-demand videos. So if you do the combo package, which I recommend, especially for those who want those test questions, it'll give you access to those videos. SurePass will give you everything, including our live review. For those who just want the test questions, make sure you get the combo package so you get those on-demand videos with it too, because it gets linked right to that test question, which is really, really nice, and then gives you additional information like references, difficulty level, how long it took you to take it, what the lesson was, all that good stuff. So here A was the right answer. So tamsulosin is the first line treatment for BPH. Very good. Going back to our PowerPoint. So jumping around a little bit, I forgot I put this thyroid slide in here, but we talked about thyroid, so I'm going to keep going. Again, when you're prescribing, for those prescribers in the audience or future prescribers, really think about the medication. What is the generic? What is it doing? How is it acting in the body? It tells us indications. It tells us those side effects, tells us how to take it. What are those risks that we want to think about? Anti-thyroid medications. So you might have patients where you identify hyperthyroidism in primary care and you have to manage them until they can get in to see endocrinology. Now, if it's a pregnant patient, I'd be picking up the phone because endocrinology needs to be co-managing and closely watching those pregnant patients with any kind of thyroid dysfunction. But if you have patients with hyperthyroidism and you're managing them, they're pretty stable, you're going to be managing them and you're going to be starting these medications. So this is in our wheelhouse for primary care. So we need to know about those contraindications and what to avoid and those other signs and symptoms of hyperthyroidism that we need to treat, like the anxiety and the eye disease. All right, let's jump into another one. Is this better for vision for the screen? Thumbs up, thumbs down, you guys. You can see it well. All right, so let's read it together. In planning pharmacologic treatment for a geriatric patient with diabetes, which of the following should be considered? A, you're going to start them on a sulfonylurea like a glipizide as first line. B, insulin like Lantus. Is that the preferred first line? C, combined therapy with the glipizide metformin, or D, single medication therapy with metformin? What do you guys think? A, B, C, or D? A, B, C, or D? What do you guys think? Weigh in here. Lizzie's weighing in. Benu's weighing in, Angelina's weighing in, Sharon's weighing in. Thank you, Sharon, for that feedback. And thank you everyone and same with Miss Doris and Angela. I'm glad you guys told me that you couldn't see. All right. Start low and go slow, says Patricia. Love it. Yes. What do you guys think? Rose is weighing in. Okay, start low and go slow. So D is the correct answer. Absolutely right. Some students will get kind of thrown by this because they'll think, oh, geriatric patients, metformin, we have to watch those kidneys. Now, metformin is one of the safest anti-diabetic medications out there. I tell patients, please stick it out because it does have some GI side effects that are unpleasant. As Patricia said, start low and go slow. It'll help with those side effects. Extended release also helps with those side effects. Eating a large meal also helps with those side effects, or taking it with their largest meal. But I always want people to understand that metformin is safe and it's super cheap, which is fantastic, especially for our patients where they have bad insurance or no insurance at all. This is a safe medication and it does a really nice job of lowering those blood sugars. In our geriatric patients, what do we worry about? We need to start relaxing those A1C goals because what do we worry about? Tell me, what are we worried about, you guys? Yes, we're worried about hypoglycemia, right? What happens in hypoglycemia? They can faint, pass out, break something. It's just a snowball. You guys have seen it on the inpatient side. You may see it eventually. We really want to be thinking about our geriatric patients really coming off of all those medications and just keeping them on what is necessary. It's my favorite thing to do, actually. When I see a geriatric patient for the first time, I love just combing through their med list and being like, you don't need that. You don't need that. Like, it's one of my favorite things to do, and just like cleaning it up. And honestly, they're so grateful. And then they'll come back in and be like, oh, I didn't have to pay for this. And my A1C levels are better. They have less anxiety. I mean, it's a win-win for everyone. Sulfonylureas, glipizide. What is the biggest thing we think about with sulfonylureas? What's the biggest side effect of sulfonylureas? You guys know this. Yes, hypoglycemia and weight gain. Look at you, Ruth, rocking and rolling. I love it. Absolutely. Falls is what Patricia said. Yeah, with that hypoglycemia, I really worry about falls, right? Same with insulin, right? I do not want to start my geriatric patient on insulin. Absolutely not. A combination of sulfonylurea and metformin. Do we ever start patients on combo meds as first line? No, and I see this in clinic all the time, and I'm like, you don't know which one's working, which one's not working, the side effect, which one is causing the side effects if they have side effects. Absolutely not. So we definitely don't want to be starting them on combo meds. Before we jump into what I was going to show you guys, because I see the time, I really want you to be thinking about when you're studying pharmacology. You want to think of the class of medication. In this class with biguanides, we now only have one metformin on the market. I want you to think about the pharmacology. How does it work in the body? That really guides us to the side effect and the contraindications. For my APRNs, you don't have to worry about dosing for the boards unless it's something specific. But dosing, you want general things, and I'll talk about that in a minute. So like sulfonylureas, dosing will be with meals because of that hypoglycemia. Does that make sense? You don't have to memorize numbers. For clinical practice, I want you to know some numbers, but these are things you're going to look up in practice. You're going to have your tools. You can look them up. Okay, how do I need to start this patient? I'm going to start them on 500 milligrams once a day and then slowly titrate up. But the boards are never going to ask you something that you can look up in clinical practice. They're looking for that critical thinking. So don't waste your time memorizing numbers for doses. But what I want you to be thinking about is the pharmacology, because look, let's look at the pharmacology of biguanides, metformin. Decrease that absorption of glucose in the intestines. Do we see now why patients feel icky on this medication? They feel nauseous, they get burps, they get loose stools. That is directly related, right? And that is an expected finding. The good thing is it does go away if they stick it out, but they have to stick it out. And those things that we talked about help minimize those symptoms as well. And then the other thing, look at this, reduce hepatic output of glucose from the liver. So if a patient has severe liver function, then no wonder it's contraindicated, because we really want to make sure that they can clear this medication, because it also works in the liver. We don't want it to reach toxic levels. Same with end-stage renal disease. So it's not contraindicated in geriatrics, it's contraindicated in end-stage renal disease. Meaning, again, we want to make sure that we can get rid of this medication and we don't build toxic levels, because it can cause lactic acidosis. One big thing, shout out to metformin. Really love how this works on the peripheral tissue. It works with that lock and key to help get the insulin into the cells. So this is a really nice medication that works even after patients have stopped taking it for 6 to 12 months. Sulfonylureas, when you're studying geriatrics, no, when you're studying pharmacology, look at the generic name, look for those suffixes, right? So know the class, know how the class behaves, and then look at those suffixes, because that'll help you know what falls in that class. Sulfonylureas are your IDEs, right? We talked about this biggest thing is that hypoglycemia, weight loss. When you learn the pharmacology, you know the contraindications. Very good. We're moving on to TZDs just because of timing. So TZDs, again, look at the suffix, right? How does it work in the body? What are those side effects? That fluid retention is why we educate our patients on those potential side effects. They need to call the office if they're starting to have excessive fluid retention and weight gain and shortness of breath and lower leg edema, because it is contraindicated in those heart failure patients because of that fluid retention, right? Our heart failure patients, we really are watching their fluids so closely to take that weight and strain off the heart. If we do not want to start them on a class of medication that actually increases that fluid retention, right? Biggest thing. So look at the biggest thing in each class. SGLT2 inhibitors. I love this class of medications. It's probably my second favorite after biguanides. Again, look at the suffixes for those SGLT2 inhibitors. Look at how it works. It promotes glucose excretion in the urine. So of course, an expected side effect is that patient's going to have increased urinary output. And it is a lot. And when you get a UA, you're going to see a lot of glucose in that urine. That is normal. However, we worry about infection, because when you have a lot of sugar in your urine, what is it going to breed? You guys tell me. Yeah, nice warm brown. Yeah, not warm brown, I'm sorry. Nice warm breeding ground for bacteria, for yeast, right? So we definitely want to make sure, even if patients don't have the symptoms, they're on this class of medication, we want to be screening them at every visit, get that UA, expect the glucose, but look for those nitrites, look for any signs of infection, ask those screening questions, right? Very important. And other thing I'll say about SGLT2 inhibitors, because of the volume loss, I worry about this class of medication in my geriatric patients. This is also a really expensive class of medication, so it's one of the first ones I usually take off with my geriatrics. So just things that I do, some clinical pearls, maybe you guys will agree, maybe you won't agree, but you'll find out once you're in clinical practice. And then GLP-1 agonists. So, Patricia, I'm not understanding your question. Third med, if all fails. So again, it's case by case dependent, right? You have to really be thinking about that patient. Some patients, it might be a good choice. Some patient, it's not an all else fail. I really don't. I'm wondering if there's a medication that I look at, like, if all else fails, I don't know. Like, yeah, I don't really think about it that way of like, oh, I would never use that medication unless if all else fails. I would definitely just take it case by case. Some patients, it can be a good option. Some patients, it's not the right option. You want to avoid it. So that's the way I would think about it. GLP-1 agonists, not going to spend too much time. Again, look at the pharmacology. You guys are pretty familiar with this class of medication because of all the hype a couple of years ago. That hype's dying down. Biggest thing I want to talk about is making sure you're checking for that personal or family history of medullary thyroid cancer, because that is a big no-no. And then the other thing, let's watch what's going to happen with the FDA research around whether it increases suicidality. I definitely avoid it in my patients with a history of severe depression. DPP-4 inhibitors, these are your gliptins. The way I think about it is these increase that GLP-1 activity, so very similar to these GLP-1 agonists, which is really nice. Okay, we'll end it on this test question. Is this the test question I want to end it on? Because it opens up a whole nother can of worms. All right, let's just do it. That's all right. I love talking about these medications. Actually, you know what? Before we go, so I just wanted to drive home the point. So when we're looking at antihypertensives, we're looking at diuretics. So you have different classes of diuretics, right? You have your thiazide diuretics, potassium-sparing diuretics, loop diuretics. You can think about what falls into those categories based on those generic suffixes. But again, think about how it works. And if you're a visual person like I am, get that textbook out, Google it, look it up. How do they work, right? Where do they work? Because that's going to give you a lot of information about that class of medication. So, like thiazide diuretics, we want to be thinking about, okay, where do they work? They work in those distal convolute tubules. So, if you're looking at your tubules, you're looking for that proximal tubule, your loop of Henle, your distal tubule, that collecting duct. And then once you realize where things are working, it makes a lot more sense why we use certain things in practice. So what I mean by that, with those thiazide diuretics, they work in those distal tubules. They're pretty mild, right? By that point, a lot's gotten reabsorbed back into the body and the bloodstream. So by the time we're blocking it at that distal tubule, we're really just blocking sodium, potassium, but these are our milder diuretics. And these are ones that we use with like milder symptoms with patients that we want to bring down their blood pressure. It's not too bad. We'll start with the thiazide diuretic. Loop diuretics, why do we hold off on these until we need that rapid diuresis of patients with really bad heart failure, more advanced? Because if you think about where it acts in that loop of Henle, that ascending loop of Henle, it's just dumping everything out, right? Sodium, potassium, chloride, it's not absorbing any of it. So it's going to give us rapid diuresis, just dumping all of those out, right? And then same with potassium sparing diuretics. Again, where is it acting? We really want to be thinking about that. That's in that late distal tubule collecting duct, and it spares the potassium. So we want to watch the potassium levels for that. Okay, I wanted to get that point across because I liked that image and I wanted to show you guys that image and how to look at the classes. But I'm mindful of the time, so let's wrap up with this exam question. Patient with type 2 diabetes, they've been taking oral medications, but their A1C remains elevated, 9.5%. What do you guys think? What's their goal? Put it in the chat for me. The patient weighs 199 pounds. Nurse practitioner is starting insulin, so that they even tell you what they're starting. They're starting Lantus. The nurse practitioner will correctly dose this as which of the following? So again, this is a case where it's again around safety. So it's not like you have to memorize all these numbers for dosing. These are things that you can look up and practice for how to titrate metformin or levothyroxine. Those are pretty basic ones, I would say. This is a safety question, right? So again, I see you guys weighing in, and Patricia says C. Let's see what our other folks say. What do you guys think? What do you guys think? Yeah, C is correct. And again, this is safety. So it's not that they want you to be memorizing these calculators for APRN exams. They don't want you to be calculating how much insulin this patient is going to eventually need, because you would not start them on 18 units, right? That's a safety issue. We're not going to start more than 8 to 10 units on a patient because their body's so starved for insulin. You give them insulin, they're going to become hypoglycemic. So you, again, start low and go slow. They eventually will probably need something like 18 units, but you're not going to start them on 18 units. It's very dangerous. Again, the other thing I want you to be thinking about is how, like, generic things about dosing. So knowing your class of medications, Lantus, right? That is not a mealtime, that is a basal insulin. We give it so that we can lower those blood sugars 24 hours, right? That's how long it works. That's the duration. So you would not be giving it BID or 3 times a day at mealtime. So again, when you're thinking about classes of medications, think about the type, the class, what generally falls into that class, generic names, And then how does it generally work so that that way you know, okay, I'm never going to be giving a long-acting BID or at mealtime, right? Its duration is 24 hours. There's no reason to be giving it BID. And I see that in practice sometimes too. Not as much recently, but I've seen it, and providers will just be like, oh, it works better that way. No, it doesn't. And we don't want patients to be just playing around with their blood sugar too low. Then they have to eat the quick sugars, 15 rule, 15 grams every 15 minutes. Then it spikes, and then it's just not fair to them and not good practice. All right, you guys. So where did we leave off? Let's see. I'm going to jump to my wrap up slide. See, I'm really bad with these rapids. I get too chatty, but I'm trying because I know you guys like them. But I want to make sure you guys know. So again, our SurePass, you can scan that QR code. This is again for nurse practitioner content. So if you are getting ready for your NCLEX and you just want to join today just to get some information, that's okay too. But this is for APRN, Advanced Practice Registered Nurses, sitting for their MP boards. You can scan this QR code. Our lovely Sarah, our Director of Marketing, put the QR code and this beautiful slide together for us so you can see our current offerings. We're building out our offerings. So this one, actually, our Power Prep is new. We did our first one in October, had a lot of fun with it. It's a one-day review. And our next one's going to be December 12th. So if you scan this QR code, it'll go to all these products and you can pick and choose what you want. And we're going to be offering them monthly. So it's a lot of fun. It's a long day. We go from 8 a.m. Central Time to 5:30 Central Time, but we cover a lot. You get all the slides. So it's over 400 slides, the PDFs of them, and they have really great content and illustrations on there. And then you also get a workbook, and then you also get the recording of it, access to the recording for 30 days. So it's really a sweet package. And I had a lot of fun, and Dr. Boosie had a lot of fun doing it with me. We tag teamed it, and we're doing it again on December 12th. So if you're looking to test, definitely join us for that. We have other things that we talked about today, that video library, our question bank. We have a combo package where you can do both together. That's what this is. But our SurePass will loop all of that in together. So that's always really nice too. I wanted to put my email address on here. I'm going to have to jump a lot of slides because I didn't get to the other things that I put in here for you. So just to wrap up, this is my email address, hiva.kolodrubetz@archerpulse.com. Remember, focus on that drug class. You're not going to know everything, but focus on the body system, learn how it works in the body, and what those parameters are will make a lot more sense. All right, you guys, I know we went over today, but I really appreciate all the participation. Thank you for joining me. Let me know if you have any other questions in the chat or email me directly. Ruth is asking, any sales? That's a really good question. I am not currently aware of any, but that doesn't mean there aren't any sales because I'm not in that department. But usually they'll tell me. I know we have a lot of good deals on once you get onto the website, and then if you put it in your cart, it'll tell you those deals. And then the holidays are coming up, so I'm sure we'll have like Black Friday stuff and Christmas stuff. We always do. But I feel bad. I don't know any current like codes I can give you guys. But if you go on the website, they'll announce it if something's coming up, or if you get on our listserv and get the emails, you'll definitely get the emails for sales that are coming out. So great question, Ruth, and great participation. So thank you so much, you guys, and enjoy the rest of your Friday and have a happy and healthy weekend.